Well, my name is Stephen Miller. I'm a physician in Massachusetts. I have a special interest in clinical reasoning and medical decision-making, which in the past 10 or 20 years has extended into studying how mental health professionals reason and make decisions, and also extended into the issue of alienation and estrangement. So I think I'm here in part today because I counsel parents in these matters, and also because I wrote a chapter in a book which I will read you. I don't make a penny from this. Working with Alienated Children and Families, a clinical guidebook, and my chapter is on reasoning and decision-making in cases of either strong child alignment, including severe alienation or severe estrangement. I'm a medical educator. I've directed several hundred courses for continuing education purposes on clinical reasoning. And I hope in the short time I'm here, I can take a 2-day course and condense it into 3 minutes for you and maybe shed a little light on how these cases go wrong. Sitting here listening to the other witnesses, it's clear there's an epidemic. The AFCC 4 years ago held a several-day conference, international conference, devoted exclusively to parental alienation. So when national organizations are devoting several days to have speakers from numerous countries come in and speak about it, you can be sure that it's a serious problem. So getting more specific, if there was time, I would comment on some of the very good things that previous witnesses commented about, but also a couple of logical fallacies that I heard and a couple of inaccuracies, including the idea that parental alienation syndrome, and I never used the word syndrome, but including the idea that it's either invalid or has been discredited. I'm an evidence-based medicine expert. That is untenable. It is unequivocally a phenomenon, call it whatever you'd like. So I mean that in a constructive way. I believe it's a syndrome. I just don't use the term to avoid the controversy. I also think what I had hoped to do is to bring a scientific view here, as some other people have done. I think it's important to distinguish between science and a belief system. One of the previous witnesses expressed the view that co-parenting has never been shown to be better than having individual custody. That's a logical fallacy. It's called an argument from ignorance. She made 2 other logical fallacies in a period of 3 minutes, and I don't mean that as a criticism. These are very common misconceptions. Finally, I'll introduce this, and try to steal another minute or two, by saying that I'm asked all the time, how could this happen? We have the best psychologist I know, guardian ad litem, attorney for the child. Oh my goodness, is that the time? And the answer is you have a complex medical situation, and there's been no medical input. And I do not mean to imply you need a psychiatrist. What you need is a subspecialist in alienation and estrangement who sees it all the time, not the best psychologist in the world who rarely sees it. And so very briefly, the short answer to this question, how does this happen, is this field is highly counterintuitive to anyone who doesn't have extensive training and experience dealing with it. Most people will usually get it wrong. And when I say people, I mean attorneys, psychologists, other mental health experts. The majority of the time, they will not only get the case and the evaluation and the recommendations wrong, they will get it exactly backwards.
Dr. Miller, I need to ask you to kind of summarize,
Yes, I'll stop
please.
now if you'd like, but if anyone would like, I can explain what some of the counterintuitive aspects are, because I think I've heard quite a few comments about it today.
Well, I'd actually like to ask a question.
Please.
You were sort of talking about the how does this happen. I'd be interested in hearing, and I think it's more in line with the task force's charges to hear your suggestions on what can be done about it.
Thank you. As I said, I'm trying to condense what I think should be a 2-day seminar into 5 minutes. First and foremost, and I mean this with utter respect, I think there's a problem with the credentials and how they use GALs here in Connecticut. As I said, I'm from Massachusetts. And I'm not a big fan of our system up there, but one thing I think they do well is that most of the GALs are mental health professionals, and there are two categories. I believe it's category E would be called the GAL evaluator, and that's a mental health profession, and most of the alienation cases, if not all of them, need that. Category F is a GAL investigator, and those are almost always attorneys. For example, should we waive privilege? That's, I think, a question a lawyer might be better able to answer. And so there's a stratification of who does what. I also think I'm sympathetic to the allegations that some people have been milking the system. I know that does happen. But my perspective is that there's a lack of expertise here. Even the well-intentioned people who want to do the right thing are way over their heads. Senior forensic psychologists, way over their heads in this type of a situation. I can give you very specific examples, which I would do if I had time. So I think I've answered your question, but I would be happy to expand if I have the time.
Well, actually, I'm not sure that you... Sorry, I'm not sure that you did.
Oh, I defer to you.
Do you have some specific strategies or suggestions as to how parents who may be exercising, let us say, excessive gatekeeping or interfering in some fashion for whatever reason with the other parent's access to the children might be encouraged to participate more fully in the co-parenting of their child, or any kind of suggestions regarding enforcement of the obligation to recognize the importance of the other parent in the child's life?
Well, I know you're an attorney, and I've been an expert witness many times, so technically the only answer I should give now is to say, yes, I do have some suggestions, but I'll break that rule and I'll give you some specifics. I think the single most difficult problem here, I'm going to give you two or three. Number one is what I call severity neglect. Unless you have extensive medical training, you're not used to putting things on a severity continuum. And the idea that a parent should be more cooperative is an extremely valid and good one, but you have to ask, does the parent have the capacity to co-parent? And I find most clinical psychologists and most mental health professionals who are not subspecialists in this area simply do not know how to determine that. And one of the things to look at is the degree of psychopathology. The people who claim PA is not a syndrome will usually say we don't want to pathologize it. But the severe cases are fundamentally different than moderate cases. In a moderate case, it is very reasonable to try to educate the parent to be more cooperative. But in a severe case, where you have what one expert's called an obsessed alienator, that person with almost 100% certainty has a severe personality disorder. Normal people just don't do that to their children. And one clue would be that they block access for years on end for trivial, frivolous reasons that you would never block access to your children for. Another indication or indicator would be the repeated breaching of court orders, which again a normal person would never do. So just to give you a glimpse of the pattern, when you see excuses like they don't like him, they don't want to see him, and I'm not going to force them, you should sit bolt upright in your chair. And when that's the investigation part proves that to be the case, and then the targeted parent has not seen the children for years on end, if not months, and then there's repeated violations of clear-cut court orders, you know, Mr. Jones, if you do this again, and he keeps doing it. Those folks are delusional. The type of personality disorder that they have, I know at least one or two of you, I think it's two of you are clinical psychologists. I have never seen such a severe case where there wasn't what we would call a cluster B disorder, which includes 4 different things. That is almost 100% sensitive and 100% specific. Now, to follow up here, to move on, I should say, I think that part of the solution would be training. As I said, I'm a medical educator. I think if we got the GALs together, if you had the judges You have their conference, and the mental health professionals have their conference, and maybe even have some cross-training. I think a lot of these problems would evaporate. Nobody who's a real expert disputes that it exists. No one disputes that you can identify it using about 10 or 12 different indicators. No one disputes that there's a huge difference between the moderate alienating parent and the severe one, and that the severe one almost always is delusional. He or she truly believes that they're protecting the child from some horrible guy. It's a true paranoid delusion. If that's what you're dealing with, I defy you to find a clinical psychologist who thinks that they can work with someone who's got a sociopathic personality disorder with paranoid delusions and, fixed paranoid ideas and so forth. So I think training would be my second solution. And I think my third solution, I don't think there are bad people, and I don't think most people are crooked or corrupt. I think there is some abuse. But I think that I'll end with the way I started. You have a complex set of severe medical problems here, and there's been no medical input, and there has been clinical input. And I want to end by really saying, I'm not saying that you need a psychiatrist, absolutely not. What you need for all the mental health professionals to do is to start looking at some basic principles, and they can be taught and they can be learned. It's not rocket science.
And I'm sorry, did you say you are a psychiatrist?
I'm not. I have a degree in psychology. I've done a lot of mental health work, but my original training is in internal medicine. I've done a lot of behavioral medicine. I used to run a forensic psych group, and I have a lot of other types of background in that area.
Thank you very much for coming.
Yes.
Ms. Verno.
Thank you for coming. And I did invite Dr. Miller because I read his book over and over again in the chapter. And when you talk about subset, or is it subspecialties, what do you mean by that? Can you clarify that? Because what I hear from a lot of people that are ordered to go to therapy, co-parenting therapy, reunification therapy, couples counseling, and there's a lot of therapists out there that say they do, when they're dealing with these high conflict cases, they're really just working as a resource and not in a therapeutic sense, or they're consultants. That's like the new trend now, that they're considered consultants. So can you elaborate a little bit on that?
I'd be happy to. I think a good question. I think the best way to do that is to just give you a list of 4 or 5 things that are extremely counterintuitive and explain why most mental health experts will probably go astray. The first, and I'll do this very quickly, I think I can do it in 90 seconds. First of all, and think how counterintuitive this is, in an alienation setting, most children will align with the abusive parent. It's like these kids that you find that have been living with their abductors for years and then they resist capture, or Stockholm Syndrome. Very counterintuitive. Number 2, what we would call pathological enmeshment, and I'll define that briefly. It means that the alienating parent has an unhealthy enmeshment with the child to the point where the child has lost his or her individuality. A severe erosion of critical reasoning skills, boundary violations, sleeping with the other parent, or at least doing the bidding of the other parent, inappropriate sharing of information, which all the lawyers have heard of. Pathological enmeshment is a very serious psychiatric problem. And to a non-expert, it looks exactly like a warm, close, loving, healthy relationship. The non-expert comes in with perhaps a PhD or an MD in psychiatry or psychology, and what they see is let's just say mother and father for simplicity, but it's about a 50-50 spread of who does what these days. The 2 little girls are tightly bound to the mother. Oh, I love you, I love you, I love you. They look at dad and say, I don't want to see him, he's a bad man. She's perfect, he's rotten. The non-expert says, wow, look at that great relationship. They really don't know how to probe to see if there are 3 types of pathological enmeshment: infantilization, adultification, making them little adults. Why don't you decide if you want to see dad? Right there, that's adultification. Right there, that's pathological enmeshment. So I repeat, pathological enmeshment to a non-subspecialist, to an experienced forensic psychiatrist, looks just like a warm, healthy relationship. Okay, another thing that's counterintuitive is, well, I just said it. Who would think that a 65-year-old senior, well-respected forensic psychiatrist, forensic psychologist would get this backwards, let alone wrong? 95% of the time, they will get it backwards because of the type of mistakes I've just mentioned. I'm giving you the short version. This is even more so true, of course, of attorneys. If the psychiatrists and psychologists are getting it backwards 95% of the time, what chance does a non-clinician have, whether you call them a GAL or an MAC? I get called in, I've got cases now in about 6 or 7 states where I've been asked to advise, and the pattern is identical in every case. You could have 6 experts against one parent, and then someone comes in from afar. I don't testify, by the way, for those cases, or rarely. And the judge says, well, 5 of my own court-appointed experts say it's him. He's perfect, she's rotten. And then one expert comes in from God knows where, from Boston or California, and says, no, everyone's got it wrong. You lose. 5-1, the judge is going to go with his own people. 2 others, and I'll be done. There's something that the psychologists may be familiar with, so I'll glance at them, called the fundamental attribution error. It's a cognitive error. And I'll even say that I think one of the problems here is there are at least 10 cognitive errors that I discuss in the book, and then another 10 clinical errors that they lead to that are made almost always by a non-expert. I don't even have to read the chart. I'm going to find all 20 of them right there. My favorite, though, is the fundamental attribution error. I have an unpublished paper I hope to get out this year on that. And an attribution error means you look at some behavior and you assign what you think is the cause for it. For example, the 3 children say, I hate Dad, I love Mom, I don't want to see him. The reason it's called the fundamental attribution error is that we're hardwired to make it. It's, even if I know I'm making it, I find it hard to override it. And what it is that you confuse something that is situational for something that is characterological or dispositional. In an alienation case, the alienating parent is probably almost certainly, if it's severe, then the alienating parent with 0.99% certainty has a severe personality disorder. They're either a borderline, a sociopath, a narcissist, or all 3. Those are not mutually exclusive.
And Doctor, I'm going to jump in here because I've actually lost track of whatever the question was that you were responding to, but it's
counterintuitive. And I'll bring it home for you.
Please.
I'm glad you. Okay. So I'm going to illustrate an example of another thing that's counterintuitive, and this is a mistake that almost everyone will make, and I found myself making it today, and I'll explain in a moment. The fundamental attribution error means you look at behavior and you think it's, if you see an angry man, someone who's angry, you say, he's an angry man. You think it's his character. In general, he's an angry man. Never mind that the reason he's angry is someone just stole his car or his wallet. We're hardwired to say, oh, I'm going to stay away from that guy. He's displaying anger. So if the anger is situational, then it's an error. Now, the relevance to us is that when an interviewer sees a severe case of alienation, the alienating parent is cool, calm, and collected. He or she is probably a borderline, a sociopath, or a narcissist, or all 3, and is a master manipulator, has learned to convincingly mimic normal behavior, and presents very well. Oh, yes, I encourage the child's relationship with his father or his mother. By contrast, the targeted parent has PTSD, has not seen the child in God knows how long, maybe years, has been told that he's the one who's the problem or she's the one, and comes in all intense, all angry, and all stressed out. Now, I personally sat through a whole course at an AFCC meeting where the person teaching the course said to the people in the group, you can go by what you see. If the parent presents anxious and intense, you can be sure that's how they parent. No, That's an elementary error in clinical reasoning and decision making, not if it's a fundamental attribution error. Okay, and that's how you leave the encounter thinking, well, it's her, not him, or it's him, not her.
Well, we're getting a little far afield from the issues before for the task force. Are there any other questions by any other members? Tom?
And I'm going to preface this by saying you're a complex thinker, and that's wonderful.
But I've lost you all.
No, you know,
That's not one.
maybe just me. When it comes down to alienation and shared parenting, I think ties into alienation. And I think it was Linda Smith at the GAL training that I was proctoring that said that alienation is incredibly complex. Yes, but it's overcome by access because it allows the child to have an ongoing relationship and establish their own understanding of both parents. And then the alienation effect is minimized. So while I think it's wonderful that you can kind of diagnose it, but you've actually just indicated that 99% of the experts that might be on a case would miss it. What we're looking at is the role of the GAL when they get in. A lot of these cases actually are resolved quickly. It's some of them that go 2 years, and only a small percentage of those are alienation. But from a GAL perspective, as they start to see something like this, their response, I would think, might defer to access when the children are of an age where they, like at 15, it's one thing, but at 10, if they're saying, I don't like one parent and I want to be with the other parent, and you can't identify some corroborating evidence to support that, wouldn't you have some kind of access and you see how that child responds? That's because it's got to be a little quicker and a little dirtier, I would think, for the court on some level. Does that make sense?
Makes perfect sense. I agree 100%, but I would like to expand just a little bit on what you said.
There you go.
One of the previous witnesses said something to the effect of you have to do this on a case-by-case basis. In medicine, we teach students whether to be lumpers or splitters, and if someone says they're an expert in wine and then they don't know the difference, all they know is this red and white, that's a problem. You have to ask, how severe is this? What is the parent's capacity to co-parent? If you're dealing with the extreme right side of a continuum, where you have a severe personality disorder, obsessed alienator, the kids are severely alienated, the principle you gave is still correct. You want to maintain contact, but you must reverse custody. I don't know a single expert who believes that you can treat that on while they still live with the alienating parent. But that is a minority of the cases. In most cases, you're dealing with a more reasonable middle-of-the-road situation. I think the court has to step in and enforce the parenting plan and have consequences when it's violated. And you're doing the child a favor. So I guess what I'm saying is that it depends. And just to conclude this, I think most experts don't understand that in the severe cases, reunification therapy never, ever works. It is a fool's errand. There is no recorded case ever in the literature of anyone taking a severe alienator. I'm speaking only about the severe cases. Where mom hasn't seen the child in 3 years, dad is, not going to change, is obsessed. And you have to recognize that's what you're dealing with. But once you recognize that's what you're dealing with, most judges don't want to reverse custody. I get it. I wouldn't want to either. So once you really are sure this is what you're dealing with, then the appropriate thing is to reverse custody. There are 2 programs in the country, I should say North America, one in Canada, one in this country.
If I could interrupt you, because I know now you're getting beyond
Just give me
where I'm
20
going.
more seconds.
20
I
seconds.
promise.
All right, but
That's
just
up to the
remember,
chair.
we have a room full of people.
I'll be
We've
done.
already been here 6.5 hours, and we have 2/3 of the list still to go.
And I have a stop.
Yes. Literally, you can hold me to it.
16.
There are 2 places where in 4 days they turn the worst cases around. There are 2 places, one in Canada run by Kathleen Ray, another in Texas run by Richard Warshak. Give them 4 days with the kid, and the kid returns to the rejected parent, happy as a clam to be reunited. But they require a change in custody and no contact with the alienating parent for 90 days. Other than that, there is no hope for a severe case. Don't even think of doing it with office therapy. But
Okay,
in the
thank
middle
you.
cases,
Thank you
yes.
very much.
So when it comes to reunification therapy in the state of Connecticut, and throughout the country, there's a lot of court orders for reunification therapy, for severe alienation. And there's a lot of money that's being made on behalf of this industry that is thinking that you're going to be able to reunify the children with the alienated parent. The court system, they don't even know about all of this stuff. And they're doing this. And there's mental health professionals who are not naive to think that they can do it. They can't. So what's the solution?
I'll give you a short answer, I promise. I think you have to ask very carefully about severity, duration, and things like that. I think reunification therapy is an excellent thing to do. I do not want to be misinterpreted as having said it doesn't work in general. It doesn't work for the most severe cases. But there's something counterintuitive here. Normal psychotherapy makes these cases worse. So if it's a skilled psychotherapist who thinks you can come in and do dyadic therapy, well, why don't you find something to apologize for? Johnny, how did that make you feel? That's a disaster. Don't try that. Even with a medium case, they will almost always get catastrophically worse. So you have to match the therapist with the kid. That's my answer. Thank you all for having me.
Thank you very much. Linda Gottlieb, did I?
Yeah.
Is it close?
Linda Kase Gottlieb.
Kase Gottlieb. Thank you. I apologize.